Today's topic hopefully will be something that you are probably very familiar with, but at the same time there may be some nuggets in there. I have to say there's not a lot that has come up in the past, 5-7 years, quite honestly. There may be some things, and I'll highlight those. But overall, it's an old disease, and you guys probably know a lot more about this than because we see it so often. And hopefully you'll still find something useful out of this. Really, to start out with, pancreatitis really is a spectrum. And I think it's really important to understand that you have the mild cases, which may not have any clinical symptoms, but they do have it. And then you could go all the way to severe when they can actually die. And it's amazing how many of them probably just stay at home, and then they get over it, and you really may not even see the mild cases. And then you'll see it maybe for a medium or severe case, and then you look back and you ask them the history, and a lot of times, oh yeah, decreased appetite for a few days, they get over it, and they keep feeding them in a way that is not ideal for some patients that are predisposed to pancreatitis. I do always tell owners that really is a spectrum. And it can actually move pretty fast. And acute ones, literally 24, 48 hours, can really change a patient from able to move about to almost dying. And that goes with the same with people, too. Just a good quick review. So remember, the pancreas has the endocrine section, the islets of Langerhans, and it's really, just remember, bad. B cells, it makes insulin, the beta cells. A cells, the glucagon. D cells, somatostatin. And exocrine will be acinar cells that secretes the enzymes, and the ductal cells that do the bicarb in water. When you are trying to digest things, carbohydrates are usually digested by amylase. Lipid digestion is lipase, cholipase, and phospholipase. And protein digestion is trypsin, chymotrypsin, and carboxypeptidase. It has a huge impact on digestion. And then how do you not self-digest yourself? And this is where you have a lot of defenses in autodigestion. And they are stored as inactive zymogens. And whenever you see the word ogen or pro, usually those are the inactive form. So you have trypsinogen, and then the active form would be trypsin. And the pro-phospholipase, A2, and then again it's a pro word. And then you have the intracellular segregation, that the zymogen granules will be kind of separated out, and so that they can't activate yet. And then you have pancreatic secretory trypsin inhibitors, and then you have the plasma protease inhibitors. And that group actually is the third largest group of plasma proteins. And those are the alpha macroglobulins, the alpha-1 proteinase inhibitor, and the antithrombin. Okay? And remember, whenever we kind of give plasma, like people say, do you give plasma to pancreatitis or not? The argument was, well, maybe we'll kind of have some alpha proteinase inhibitors in there. Pancreatic secretion, the cholecystokinin, it comes from the eye cells of the duodenum. And the stimulus is from protein and fat digestion. So I think it's really important that protein is also a big part too. So it's not just fat. And they could really start to stimulate the digestive enzymes. And it's absorbed into the blood and it stimulates enzyme-rich pancreatic secretion. So sometimes when I have an animal that's really sick, I'm also a little bit cautious about super high protein. But when they're eating so little, it's like that bite of chicken who really doesn't do much. But you could definitely mix in the carbohydrates, like pasta and rice. It's easy. And then secretin, it's a source of the S cells in the upper small intestines, and then that will help. Acid is in the duodenum. That's a stimuli, and it's absorbed in the blood, and that's where you will start to stimulate secretion of bicarb-rich fluid. So it really provides this optimal pH for the enzymes. Really, what's happening is that sometimes what you'll see is the pancreatic enzyme activation, it's failed, the secretory process, and then maybe the lysosome and zymogen granules are starting to fuse early, and then you often can have a lot of reflux in the duodenal contents. And it really overwhelms the pancreatic secretion, secretory trypsin inhibitors, and then it starts to activate other enzymes, and then you have a lot of free radical cell membrane injury, and it really overwhelms the plasma proteinase inhibitors. And really, again, the zymogen stuff, they're really harmless until it kind of gets mixed together. And what's interesting, I don't feel paper, I guess, they try to look for this. Maybe this is what's happening in some of the pancreatitis, but I guess it's most common in people. But in animals, they don't do reflux as much, but they can. Other triggers of pancreatitis, you have hormonal imbalances, maybe altered fat metabolism, and then obviously the big one is diabetes mellitus. Which comes first? Was it pancreatitis that caused diabetes, or the diabetes is triggering the inability to process fats and overwhelms the pancreas? And then Cushing's disease and the hypothyroidism, again, these are all imbalances in how you deal with fat. And hypercalcemia, I know it's really rare, but blood calcium can activate stored digestive enzymes. I'm trying to think of, hyperparathyroidism. I don't recall a lot of them coming in. They're just coming in for, PUPD, not typically pancreatitis, but at least by definition it can trigger that. And then drugs, there are some sulfur-containing drugs, azathioprine. There's a whole list of drugs, and they really don't know for sure. But there are definitely, we know confidently with potassium bromide that really can trigger pancreatitis. So if I have a dog that's predisposed, I prefer to not use potassium bromide, and which can be really tricky because some of the really bad epileptics, they may need a little bit of bromide. So what's interesting is that most people are familiar with dogs with pancreatitis. They're really classic. And they vomit, abdominal pain, and not feeling great. But cats are just funky because ultimately, majority of them won't want to eat, and they're usually a little bit dehydrated. And now they can start to be a little bit hypothermic, but at least 68%. And vomiting is 35%. And I found that's interesting. It's much lower. Only a third of cats will vomit, and the majority of them don't. And then abdominal pain, because they're just too tough, they're not going to show it. So I guess it's kind of hard to assess, but a lot of times they're pretty soft-bellied. And then sometimes you can feel like a mass on palpation, dyspneic, ataxic, and diarrhea. But again, these are minor, but I feel like the classic dog vomiting, abdominal pain is so straightforward, and cats, they just really just decrease appetite. So because these signs are so vague, this is where it's really challenging because it's not very obvious that they have pancreatitis, and that should be on a differential list. The diagnosis of pancreatitis, you look at the history and signalment, the CBC, chemistry, and then I really don't use amylase lipase at all, and I think most labs now, they don't even have it on there, but occasionally there are some. I mean, it's fine, it's in there, if it's really high, great, but just don't really put too much weight on it, I would say, because it's so nonspecific. There's so many other organ systems that secrete that, and then it really has an impact when you're dehydrated, because remember the GFR goes down, and that's how you clear the amylase lipase, so it'll be really high just because you're dehydrated. And then for cats, it's all over the place. So even, don't even look at it for cats at all. And I know in humans, there's still amylase lipase, so I do feel that a lot of human physicians will ask about that, and I do find that we'll go over, this is more the common test that people are really running now. The CPLI, doesn't matter if you go to Texas A&M or IDEX, and then FPLI, and then Precision PSL from Antec. Okay. And then radiographs and ultrasound can also be quite helpful. So the history, really, I try to look at dietary indiscretion, any drugs, and trauma. Occasionally you will get the traumatic hip car that is having a hard time recovering, and you find out they actually have pancreatitis. Infection, toxoplasma is a big one. Occasionally you get the liver flukes, FIP, calicivirus. Those are all things that have been identified with pancreatitis. And then, of course, if you're in Trinidad and you get bit by some scorpion, I know there's supposed to be some Trinidadian scorpion that causes pancreatitis, so that should be on your differential. You ask that if they've been to Trinidad with their cat. And then recent surgery. Specific causes are not apparent in cats. That's the frustrating part. We really don't have a link. It just happens. And often has concurrent disease involving the liver or small intestine. So we see a lot of inflammatory bowel disease in cats, and I do think that it's probably more adjacent organ system, and they're all kinds of triaditis. They all kind of talk to each other. They start to become inflamed together. And what's interesting is that really you can have signs even from less than 3 days to like 12 weeks. So cats are just this like, oh, poor doer. And those are the frustrating ones, actually, the chronic ones that are just like, how do I get over that hump? You know, and you can never get through it. And then I find that some of them, if I really treat for inflammatory bowel disease, if I actually diagnose there's something else, I feel like it's a little bit easier to deal with the pancreatitis. But then some of them are just poor doers, and I have a feeding tube in them, and I'm treating for inflammatory bowel disease. It just kind of like, just kind of hang in there, but you could tell they don't feel good. And there's definitely obviously breeds that you're very familiar with, all the hyperlipidemic dogs or hypercholesterolemic. You know, there's a primary form. There's, remember, triglyceride versus cholesterol. They're two different things. So if you have that layer of fat, that is going to be triglycerides. And then cholesterol could be super high, and you don't have to have that layer of fat. And then sometimes you have a combo. And then a lot of times the small dogs. And then maybe Siamese and Himalayans are also a little bit higher risk in cats. And I find obese animals, and who knows, is it because there's just so much fat, or what are they eating to get so fat? You know, so who knows? And then endocrine disorders, so Cushing's, diabetes, hypothyroidism, and then again I talked about hyperlipidemia, the cholesterolemic ones or the triglyceridemic ones. And then hypercalcemia, again, that's a lot of papers will say that, and there's been like some association, but I don't see that as practical for the cases I see with hypercalcemia. So association is definitely cholangiohep, and that's, again, it's because the bile duct merges with the pancreatic duct in the cat compared to the dog and the humans. Inflammatory bowel disease, and they can also have low B12 then. With this, so it's never wrong to run a B12, and they're like, ooh, you also have low B12, and they may need to be supplemented. But if I have a low B12 and I have a pancreatitis case, I don't run B12 on all my pancreatitis if it's just straightforward, but if there's a weight loss, there's a potential primary GI, I think it's something that it leads me toward, you probably have something else going on intestinally. And remember where low B12, what part of the GI tract is affected? So it's what part of the small intestine? So the ileum. So this is a tricky part. When I have a vomiting cat not eating, if I go upper GI, I'm not going to touch the ileum. So now a lot of arguments are people want to do both upper and lower, but sometimes it just takes more time to kind of clean out the colon and such. But at least that tells me a little bit there's an ileal malabsorption. And then hepatic lipidosis, again, it's interesting because about 40% of fatty liver cats do have pancreatitis, and they're often overweight, and there's a coagulopathy because remember the biliary congestion, a lot of your coagulation cascade has to go through the biliary tract, you know, the vitamin K family. So that's where a lot of these guys, they do need to be supplemented, sometimes a little bit of sub-Q vitamin K. And then you can have peritoneal effusion too. So if you have a pancreatitis case, I'll see that there'll be free fluid, and you have that bright fatty liver on ultrasound. So there's just an image of the bile duct coming down, and then you have the pancreatic duct. They share into one opening, and this is what's so tricky versus the dog and humans will have its two separate openings. And you can imagine any little inflammation can really kind of cause a little obstruction or partial, and then the bile just kind of gets congested pretty heavily. The CBC is highly variable, okay? So you could definitely have the left shift with dogs, but less so in cats. Mild anemia can be sometimes non-regenerative in cats, but occasionally we will also see it increase because they're usually pretty dehydrated. And then occasionally we will see thrombocytopenia when it's really severe because you're like going toward the DIC range and such. The biochemistry. So you have a lot of pre-renal and renal. And this is where you really need to always get a urine-specific gravity. You have that one window of time to collect that urine, even if it's a tiny drop, just so that you can know, is there a concurrent renal? Because so many cats have renal disease, and once you start fluids, you don't know what the renal status is. And I've seen pretty severe pre-renals that you can really correct once they get hydrated, and they're not renal failure, because you don't want to give a negative prognosis when it's really just pre-renal. So liver enzymes are going to be quite high, hyperbilirubinemia, and a lot of times we will see a little bit of hyperglycemia. I feel like I have a dog that's really sick and I see the glucose a little bit high because they don't get the stress hyperglycemia in dogs. So I start to go, I wonder if you have pancreatitis, that's making you feel sick. And but then if you start to see hypo, then that's bad, because then you worry about sepsis and toxemia, and you're really decompensating. We'll often see the low albumin because of the vasculitis. When they start to have infusion, they'll start to leak out a lot of the protein. And it's not from liver failure, even though your bilirubin's high. That takes time for you to stop producing albumin. There's a lot of reserve, so there's usually a leaky vessel issue. And the hypocalcemia, of course, is oftentimes with the low calcium and with the low albumin. But sometimes it's because it's kind of getting saponification in the fat, so they kind of deposit the calcium speckles in the pancreas. And some of it's going to change the PTH homeostasis, about 50% of the cats. And there is variable alterations, depends on how much they're vomiting. So your sodium, potassium, chloride could be a little bit off, and a lot of times they're not eating, and they get really depleted. And those are the situations where you really need to have potassium supplementation, even if it looks normal. You know, once you hydrate and such, sometimes they're going to use up the reserve when they start to shift, because they could be pretty acidotic too. If they're really, really sick. And then you have the hypercholesterolemia in cats more because of that biliary duct and the pancreatic duct merging. Unless like you have a Cushing-noid dog or a diabetic, of course. Urinalysis, we kind of talked about it's so critical to get that window of time to appreciate if it's a pre-renal. And you can have a transient proteinuria. And then you just want to make sure there's not a pyelonephritis that's causing abdominal pain, because pancreatitis and kidney pain, they all kind of look, and back pain, they all kind of look similar. And then, of course, if you see glucose or ketonuria, you're worried about this is going to be, a diabetic now. And in cats, remember, they could be transient. And then in dogs, I had one was transient. It was for 4 days in the hospital. I'm like, oh, you need insulin. And it was one of those things, I don't know how Dr. Calfee got it for surgery. And then I was like, oh, you're crazy. It's of course it's diabetic. And then he goes, well, it wasn't, a few days ago. And I'm like, once a dog is permanent diabetic, that's it. And then of course he did something, I think, to that dog, and ultimately the sugar normalized. So I don't know how, because they needed 3 days of insulin, and it calmed down, and then he didn't have to go home on insulin, which is really unusual for me. And then just remember, if you have glucose in the urine, you can still be stressed, okay? There's a time I remember they learned that, that's how you differentiate between stress versus diabetic. No, cats can be so stressed that they can't have spillover of glucose. If you're really not sure, you can always run a fructosamine. You're like, how long is this going on? Do I really need to start insulin? And I just have to be very careful with insulin therapy in a really active pancreatitis cat one, because I do find that fluid therapy will help them out a lot, and the sugars can come out down nicely. And they don't need as much insulin as a only diabetic, brand new. Amylase lipase, if they're not very specific, you can definitely have intestinal disease. Corticosteroid administration can release lipase, and renal disease. Both enzymes will go up from GFR decreasing, and and there's all these other types of lipase, fat cells, liver cells, intestinal cells. And then you can see all the range all over the place, for confirmed pancreatitis and if it's normal. 28 to 61%, that's pretty high. So, and then 31 to 47, and then they were talking about sensitivity and specificity for both. And then you have the pancreatic lipase immunoreactivity. This is a ELISA to measure pancreatic lipase, so it's very specific to the pancreas. So you'll have a few papers, and they're kind of all over, but overall the sensitivity is pretty good at 96% and specificity at 82%. But I think it's really important to know that, is it a mild case, moderate case, or severe? If you start to pull those papers out, those are tricky. And when you have these big studies, they don't really say these are all the mild, and I'm going to run a sensitivity specificity, and these are all the moderate. And what is considered moderate? What's your gold standard? Unfortunately, who's getting biopsies of these pancreases? So I think that's where I find it very challenging when you have to interpret these papers with a little grain of salt, like what is your gold standard? But I thought that's just kind of an interesting look, because mild cases, maybe it's only 21% will be picked up, and then the moderate, hopefully, obviously, the worse it is, it's going to be more obvious. And then cats, there's a little bit even trickier, the FPLI, but really we don't have anything great out in the market. And so the FPLI, I think the sensitivity is maybe 70%, and then maybe specificity is 83%. So the sensitivity is 70% and specificity is 83. So it's kind of similar for the specificity with the TLI, but again, just realize, you could lose 30% of your cases, right, if you're thinking around 70% that truly have it, but you're not able to detect it. So you really have to look at the whole picture. But the nice thing about it is not affected by renal disease, and that's where a huge improvement on this type of test. But lipemia and hemolysis can. So this is where it's tricky. If you have a really, really fatty spin down, occasionally they have to really kind of clarify it. I know IDEX does a double spin and they do things to it to get rid of the lipemia. And then I always worry that if you do pull blood and you're sending it out and it's not going to go out till tomorrow, make sure the people are spinning it down and separate it before you submit it, because a lot of times you can get a lot of artifactual things too. And then you have the SNAP, and that's it's pretty strongly correlated. But again, I find that sometimes if it's a moderate case, you're probably going to be positive or a severe case. But you have that gray zone one that I feel like it's not going to be able to pick it up. And if you notice, there's nothing 100%, okay? But I like this. I don't use it much for internal medicine because most of the time they're already kind of referring to me or getting transferred to me. I'm going to treat it as a pancreatitis, so I kind of want a quantitative number. But I can imagine on the ER they use it a lot because it's do I go to cut for surgery? Is it a foreign body, or is it going to be pancreatitis? And if it's a negative, it helps me. All right, you better start looking for something else potentially if you're that sick. And a cholangiohep is another good one. Wow, your liver enzymes are crazy high and your bilirubin's high and your SNAP is negative. That makes me start to look like it better not be a mucocele, you better not be a obstruction or a mass, leptospirosis. Those are all things that can be helpful. So I think it does, especially if you don't, because we're lucky to, even IDEX, we still have to send it out and we get it the next day, but still sometimes you're in a situation I want to make that decision now. And I think it's really important that just because it's a negative test, you can't be 100% it's not pancreatitis. But again, look at the whole picture. If you have a really severe case, it is unusual to be negative, though, I have to say. If everything kind of fits, the pancreas looks ugly on the ultrasound, free fluid, everything fits. So now the IDEX, that original test is all from Texas A&M, and then I think they sold it to IDEX. So now they renamed it for the SPEC PLI, and they are very specific to the pancreatic lipase. So this test, again, they have a different sensitivity, so at 83%. So the original paper was from a Texas A&M when it came out, and then now this is the IDEX one. And so the specificity is much, pretty good, but the sensitivity, you're 83, which is not bad, right? But you just have to think about some cases when we miss. In cats, maybe 80%, and the specificity is maybe 82%. And then there's precision PSL, and this one, they feel like it has a very close agreement with a CPL. Okay, so this is a crazy long name, so they call it DGGR, and lipase assay. But if you look in these kind of papers, you look at what is the gold standard. So the original Texas A&M, they did do biopsies. So it's great, that helps me. But then later on it starts going, all right, because this is a gold standard and this is the normal, then they start to compare it to the assay itself. And that's what this is doing. The precision PSLs is comparing it to the other assay. But then if you start to use your gold standard, and then this is the sensitivity of it, and then you do another test to kind of match that one, you're going to get farther and farther away from the gold standard a little bit. So just be careful of that. But again, at least they did look at ultrasound, and it was suspected pancreatitis, but ultrasound you'll learn later on that it's not also 100% either. So these are just not perfect, but it is what it is, because it's hard to just recommend surgery on these guys. So trypsin-like immunoreactivity, so this is great for EPI. So sometimes you stumble on this when it's super high because you're actually looking for a diarrhea case, and you're like, ooh, TLI is really high, but sometimes it can be actually from pancreatitis, because we do know intestinal disease is associated with pancreatitis. But if it's low, obviously, you have your diagnosis of EPI. But if it's high, it probably suggests there is some kind of reactivity from the pancreatitis. But not all, so sensitivity is even worse. It's at 37.5. And so we don't use that anymore. There was a time that because the FPLI was not present, people were using TLI for your pancreatitis case in cats because we knew amylase lipase was horrible. But even that it's not great. And it definitely gets affected by renal disease. And we see a huge increase in IBDs and GI lymphoma cases, even though the normal pancreatic histology. So anytime I have a paper that says, hey, we actually did histopath, it helps me to understand what their normal, what their gold standard was. So radiographs, it's really going to often be absent until you have a more severe case, but I think obviously you're trying to rule out foreign body, especially in a dog, so I don't think it's wrong to ever do radiographs. But sometimes you will look for loss of serosal detail, the passing in the right cranial quadrant, but really I've seen it also just in the cranial quadrant in general, and then you often will see displacement of the duodenum ventrally or to the right. You definitely can see this hypomodal duodenum, and you have a caudal displacement in the transverse. Just think of where the pancreas lies and just imagine super swollen, and sometimes they look like mass-like. Like on ultrasound, it's impressive. They're like so chunky that it really does look like mass-like. Unfortunately, it could be normal, but you are looking for like pleural effusion, and you kind of get a little bit of a chest in there. A lot of times we'll kind of say, oh, you have pancreatitis, but wow, look at that pleural effusion. And I really like when you do the VD, I look at the costophrenic junction. That's a great place to see for fluid. Just a hint, it would be like a smooth round versus you should have a nice tapering in the black lungs, you know. So that's a great little tip for the pleural effusions on VD. And you definitely have a really bad case, you can get edema, you know, the non-cardiogenic pulmonary edema or pneumonitis, interstitial pattern. It's a little bit heavier, and it does go away because it's almost like SIRS, severe inflammatory response, and then now your whole body's become inflamed. So you get pretty bad vasculitis. Ultrasound, I feel like this is really operator dependent, machine dependent, and so sensitivity can be up to 68%. In cats, they're a little bit trickier, but it can be up to 67%, but as bad as 35%. And these are all just different studies that kind of looked at ultrasound. And the specificity is not bad, for sure, but I just think that it's great when you see it, but you can never rule it out, you know, if it's normal. I just get so much out of an ultrasound anyway, because you're looking for biliary obstruction and duct dilation, peritoneal fluid. So a lot of times I'm trying to get prognosis for the owner. So are you going to spend all this money on this animal that has necrotizing pancreatitis because you could be in it to win it? You know, you're talking about in the hospital for 5 to 7 days, if not more, versus one that doesn't have any effusion. Because once you have the abdominal effusion, that's really scary. And the next thing you know, they're going to have to go into respiratory distress. You know, they usually start to get pleural effusion or they're vascularizing their lungs, and they die from respiratory arrest, not just from the pancreatitis. And then I think it's really important to look at pancreatic masses and also sometimes even like abscesses. And pancreatic masses are interesting. Sometimes I see a really ugly pancreas that looks just like pancreatitis, but the dog's not painful. You know, liver enzymes are high, but you're not painful. You're not really vomiting, and then I'll run a PLI, and it'll be normal, but then you have effusion, and usually those are I worry about pancreatic carcinoma. They don't have to have active pancreatitis at all. You just have an ugly pancreatic mass. And this is just like some old, it's pretty not the best images, but just how edematous, the surgery. Look at it. I'm sure you guys all probably have seen ugly pancreases more so than myself, so. And then really to diagnose it, you need the gold standard is biopsy. But the reality is that do we ever do that? And remember, they could be multifocal. You know, just like intestinal disease, I don't just go in and just get one little sample when I do scoping. I'm going to get like 20 to 30 on the stomach and maybe like 15 to 20 on the duodenum. And you would hope your surgeon's not like sitting there making like Swiss cheese out of, you know, your pancreas. I'll be like, ah! But they try to find an easy area, but I do find that some of the even issues with gold standard being pancreas, unless you do it on necropsy, you know, where you're really going to get different slices. So, but it's really rare that we ever have to do that. I mean, occasionally we're just trying to figure out if it's a mass or not, if something's not fitting, and then we may go in. The histologic diagnosis, if you do get a chunk, it's, you know, necrotizing pancreatitis. Those are really ugly, and then you can have the acute separative. That's mostly neutrophils. That's probably the more common one we see. And then the non-separative. It's like the lymphocytic, plasmacytic, and fibrosis. The real question is this just a spectrum going this way? You know, it's not just like three different individual histopaths, but really it is a spectrum potentially. You know, you may start out there, then it's getting pissy, and then now tissue are starting to die, so the neutrophils are coming in, and next you know you have dead tissue. So Who knows? So let's talk about treatment. So the treatment for pancreatitis, do you rest the pancreas? I mean, that's kind of like what we were taught a long time ago, and now we're like, no, feed the, the gut at least. But I still I have a hard time when the animal's vomiting. I'm like, kind of try to shove something. I'm like, just let it, fast for 12 hours and just try a little tiny bite. I still like to feed, but just very carefully, and but not truly fast forever. And then IV fluid support, colloids, and then the question is, antibiotics, pain management, anti-emetic. So we'll kind of break it down, okay? I do think fluid therapy is just really important. If the owner won't hospitalize a patient, at least minimally give us a sub-Q fluids. They may have to come in daily, whatever, because you really want to try to avoid that ischemic injury because they're really having poor perfusion because they're really dehydrated. They're really not going to eat or drink typically. And if they do, they may just vomit it up. And then just be very careful if you're on IV fluid support not to overload them because their albumin is quite low. So they can start to get vasculitis, and then they're kind of leaky, and next they're seeping everywhere. And then I like to supplement with potassium because they're not eating, and usually they're not going to eat for a few days. It's always safe to kind of add a little potassium to their fluids. It can also become low again when they're acidotic. So that potassium and hydrogen ion shift, the proton shift. And then important to monitor, especially if it's diabetic. Okay, I can't tell you how many pancreatitis cases, DKA, people look at the potassium, it's like even 3.9. You're like, oh, don't worry about it. It's going to come down once you start insulin. That insulin's going to pull that potassium in, and now you're really depleted. So most of my diabetic DKAs with pancreatitis, or just DKA in general, they're probably on 40 to 60 milliequivalents per liter. And then I've done one time, it was 180. It was just so but you just have to watch the fluid rate, obviously, because you don't want to have a higher risk of cardiogenic issues when potassium's so high in their fluid concentration. But you'd be surprised, they just need a lot. And then colloid, do you give plasma? So again, the arguments may be alpha macroglobulins. It's kind of coming out of fat. It comes in fat, out of fat. I think that I used to, if I have a really severe case, I'll definitely do some plasma. But our curriculum says, oh, don't do it. No one does them anymore. And then it just varies. Then I have another curriculum that said, hey, yeah, you can. So I think it's all over the map. I feel that when we're really desperate, you have that acute necrotizing pancreatitis, they're starting to fuse, you really want some colloid help. I'm not using the plasma for the true colloid, though. I just don't want to, I'm using more for alpha macroglobulins, because if I really want that colloid support, I'll be using vet starch or, head of starch. Or if the albumin is so low, I'll be giving a canine albumin transfusion. Because I'm definitely not, it's just too wimpy for colloid support for plasma. But it does have some albumin, but it's really not as effective as vet starch or head of starch. So it does help bind detergents, the free fatty acids. So ultimately, I think plasma can be helpful, but is it going to make or break them? Who knows? And I think plasma also is really helpful because it does help with DIC. And then they're about to go into it. My argument is well, then plasma is definitely going to help with that. So, but maybe we're not there yet, and you're going to go in it. So that's my thought when they're super severe. Head of starch, again, I'm using it more for oncotic pressure because you'll notice that if you are blasting with crystalloids, you start to get all edematous and they're really uncomfortable, and you can't easily overload them. So I will have to kind of reduce my fluid crystalloids so I can at least do vet starch. And you especially will be helpful for cardiac cases. They just can't handle too much. But remember, it doesn't pertain to any of the protease inhibitors. And some people, it can aggravate bleeding tendencies. And maybe it can help with microcirculation with antithrombotic effects. But there was some studies that showed that even when you use head starch, they're actually worse. They die. But then those are the population that you're kind of going to die anyway. So those are hard to say. But at least that's when in humans.
Are you using much of that if you're concerned if they have either renal or pre-renal, and the whole scare about head starch?
I still don't, not dramatically, because it depends on if I have to blast them with crystalloid and you're getting infusion, I'm sure that's not going to help your renal, you know what I mean? Yeah, exactly. So sometimes I just really want to watch my volume, and that's the thing. So I do not.
You say that you're monitoring all these things. On what kind of frequency or schedule? Like your potassium, are you doing it twice a day, 3 times a day?
I think it depends on how low it is. If it's definitely low, and especially my diabetic, at least it's every 8 to 12 hours. I start to, you come out of residency, you're like, oh my gosh, I'll do it every 4 hours. And then, but then it's like, all right, that's silly. And then you start to be very practical. And so I feel like if your potassium is truly low, I think every 8 to 12 hours is reasonable. And then you start to back away to maybe just once a day to make sure you're checking something to you're on the right track. And then I stop, And then, but I do think potassium could be a tricky one that people don't realize how low it's going if you don't check it again because you came in normal. That's the ones that I feel like is challenging, especially if they're just not eating a lot and you're really not putting that feeding tube yet and you're like, I'm waiting, and then the potassium is getting depleted. So do you do antibiotics or not? So remember, pancreatitis is a sterile process, okay, as opposed to humans. But I do have to say cats are just funky because they get cholangiohep. They get, the whole bile duct and the gut, they're all kind of shared in the same area. I feel like they can have more issues. But in general, they're so decompensating. A lot of times I have diarrhea. I have a lot of GI issues with my patients that are just so sick, and I do get a lot of translocation of bacteria. So I will put them on broad spectrum antibiotics, but I just want to stress that sometimes you're like, oh, he has a fever, that's why I'm putting antibiotics. Not necessarily, because you could have a sterile pancreatitis, you have fever, It's not necessarily necessary from infection, because sometimes I've seen people like, I'm already on Unison, I'm already on Baytril, I'm still freaking out, and I'm going to add more and more, but let the pancreas calm, and eventually that fever will go away. So there's a reason. It bothers me when I have a fever and I can't find a cause, So, and then of course diabetes, they're already immune compromised, so this is one where you want to make sure that their sugars are pretty well regulated. Because the super high sugar is not going to be good for recovery, for sure. So I'm a huge fan of diabetes, definitely CRI insulin, because you can really tailor the glucose. My goal, if it's in the hospital, they should be in the 100s for their blood sugars, when they're in the hospital. And that's the easiest to control when you have a crashing diabetic, because I could literally adjust the CRI insulin accordingly by fluid rate, versus you go into long-acting, those are just all over the place because they're really decompensated. And we're huge, we tend to do Unison a lot. And if I have one, remember Unison is a ampicillin plus sulbactam, so it potentiates that ampicillin. It's a beta-lactamase inhibitor, so very similar to IV and Clavamox. But if I have a really strong gram-negative E. coli family, a gram-negative concern, I will add in Baytril too on top, because Unison's great for even E. coli, but not as strong as for quinolones, especially in a very harsh environment that's very purulent, for example. Like a pancreatic abscess, because just like for the same reason why we use fluoroquinolones for prostatitis, infection, because it really is a harsh environment. Some antibiotics, it can fit and it looks like it should get it, but then it can't survive that really nasty purulent environment. Remember the anatomy for the pancreas, and this is why the colon runs right adjacent to that. So there's a lot of inflammation that's so severe. We do see more permeability issues, and that's why the translocation of bacteria can happen. Pain management. It's going to be really important, obviously, to keep them comfortable. Butorphanol, buprenorphine, and then you have the pure agonists. And a lot of criticalists, they kind of like the pure stuff versus the mixed. But ultimately, you just have to kind of use your judgment and how painful they are, where we try to palpate, and we have a pain score for all our ICU patients, and then when they're kind of checking them out to make sure that they are very comfortable, and our nursing staff is great, and they'll let us know when they feel like we're not doing it, when we're just using butorphanol. That's really short-acting, it's kind of wimpy, so sometimes we'll go a little bit longer, but really a good one that we used to always do, but now we use methadone, is a good one, but the, I forgot to add that one in, but lidocaine ketamine CRI drip is another great one too. Anti-emetic, anti-nausea. I'm a huge fan of Reglan in fluid because there's just so much ileus going on. I'm not using it for the anti-emetic effects, but it's a bonus. But I think I love CRI metoclopramide in all my pancreatitis cases. I feel like because even if you want them to start eating and your stomach is just not emptying, you just feel more nauseous, and then it's eventually going to come out. And I feel metoclopramide is great. But remember, if you are going to send it home or do oral, I see a lot of people only do like twice a day. This is a very short half-life when you take it orally. So you have to give it at least every 4 to 6 hours if you really want to give it to mean it. But most people can't do that from a schedule standpoint, so at least every 8. But I feel that it's one that I was right. Every 8 hours, but it can increase up to every 4 to 6 hours if needed, for vomiting, decreased appetite, and such. And then you have Zofran. At least now it's generic, so it's much more reasonable in cost. And there's some Dolancitron. But ultimately, we use Cerenia quite a bit. And now there's always like magical powers of Cerenia. There's like anti-cramping. It makes back dogs walk again. I don't know, like just like crazy stuff. So if you guys invest in stock, I should have done it. But it is one where I think it does quite a lot, and especially with cramping and such. And remember, they have the 160. So sometimes I will have a big dog. I could use a quarter of a 160, or versus like having like 3 tablets of the small ones. So I do like the 160s a lot. Anti-acid secretion drugs. Maybe it helps with reflux esophagitis, especially when they're so bloated. The food is kind of like, they're doing reflux all the time, and and some of it eventually will come up. So I do feel like it can be helpful. I think that we are in a situation where we tend to treat probably esophagitis and reflux probably more often than we really need to. I think it's one of those things in vet school. I remember like immediately, back then it was not pantoprazole, it was famotidine. It's like everyone gets famotidine. Then now you're like, why? And then usually it's one where we probably overdo it, but ultimately if you are concerned about reflux or just that nausea feeling and it is kind of going up, we like omeprazole because you want to get rid of the pump altogether. So remember, all the other H2 blocker, it only just does H2. Because remember, the proton pump, it has like 3 receptors. So you have the H2, right? And that's your histamine 2. And then and that's why, like for mast cell tumors, you want a histamine 1 block too. So that's why you do the H1, H2, which blockers. But then the other one is gastrin. You can't do anything about that. Gastrin's still going to be secreted, and that's why I'd rather just knock out the pump, and that's why omeprazole works much better than just a pure H2 blocker. And then remember the third receptor is acetylcholine, which you can't do much about that either. Okay, so this is why omeprazole definitely has shown that it is stronger in looking at the pH in several different studies, that it's more effective. You can go up to twice a day if it's really, you want to give it to mean it because there's some concern about ulceration or something like that. And there used to be a time that you can't split it. You're supposed to not give it whole, but a new study came out that you totally can split it. So, and they come in 20 milligram tablets. The nice thing about it is there's a pretty huge range. You could go to like 1 mg per kg, so therefore the average cat can easily take a quarter tablet. And it's hard to overdose, it's not one of those things. So you can try to do a quarter tablet. There used to be the capsule that were omeprazole that they have little pellets in it. They're little capsules. And those are pretty cool because you could open them up and you count the beads and you could really. So if you're doing that, the only downside is you're supposed to put it in bicarb. I remember learning, I don't know if you still have to do that, but I remember our pharmacists at Ohio State, because we used to get, gastronoma. It's like pretty rare, but you get it in cats and such. And I had a gastronoma case, and ultimately we would open up the capsule, and she would put bicarb and mix it for that concentration, because it has to be bicarb to be stable. When you can't just pop it in the cat's mouth or something. And so she would make it up for us. But now the nice thing about compounding pharmacies, it's everywhere. So you really have to you have these little tiny, like 3-kid cats or something, I'm sure. You can make it, the pharmacist should be able to know what kind of formulation, because sometimes it is pH dependent on the stability. Okay, nutrition. Typically, in dogs, are they really MPO? We really shouldn't be MPOing them, but they're kind of naturally doing that. By the time they come to you, they've probably not been eating for 1 or 2 days, 1 to 3 days or so. I do try to tell owners, try to offer water at least, and then add a little bit more food. But ultimately, you're really going to have to put a feeding tube in. And now that we have a critic list, I noticed that they do that almost automatically, pretty quickly, which is great because I never thought about it. I'm like, yeah, because they do have a lot of ileus, and some of it's just fluid filled. When we ultrasound, there's just a lot of ileus. You just want to get rid of that, just so that you can suction that out. And then it's great to have access because now you have a trickle feeding system that you could start to give a little nutrition as long as they're not vomiting. So I do think an NG tube is really reasonable, but the downside is NG tube really should be hospitalized. Okay, you try to send an NG tube in an animal, they're just going to like mess with it, and the owner's going to be calling you to try to sort that out. But we're pretty aggressive with NG tube from the hospital. Now, cats, if I have a bad pancreatitis, I usually give the talk that you really need a feeding tube because it could take days to weeks, and if you're not eating, I'm trying to avoid fatty liver, and sometimes I already have fatty liver, and I really am putting them in very quickly. I used to, as a resident, I was always a peg tube person. And then now looking back, it's like we probably should have done E-tubes because it's just a little bit very cost effective, super easy in a sense that if it really comes out, the cat doesn't die. Versus like when you have that peg tube placement, if you have to have a mature stoma in about 14 days, and then if they do something crazy, it really is scary. And so now E-tube is definitely the way to go, I feel. And the nasal gastric tube, you can, but ultimately your cat's going to try to send them home as fast as you can because they're never going to do anything in the hospital or eat and such naturally when they're not feeling well. So I feel like the NG tube in a cat, I say spend the money and just put in an E tube. If you're going to be committed with the NG tube, you're going to be in there at least 3 to 7 days, in the hospital. And in J-tube, there was a time that, you think about, do I need to put a J-tube in? And people were bypassing the stomach. But there's actually a lot of studies that they say that the secretion, because that's what the whole point was, why do you MPO? You're supposed to stimulate you're going to stimulate the pancreas, and the enzymes are going to get more pissed off. They did studies that actually they feel like your system is so out of whack, you're not even secreting properly anymore. Because you ever kind of release some of the enzymes and you're doing your own thing, so it's not triggered by food anymore. And I do think that with enteral support, it really probably decreases the systemic inflammatory response and translocation of bacteria, rather than just because you're bypassing or worry about pancreatic secretion. It has to do with decreasing inflammation and really translocation of bacteria because you're making the intestines happy because they do need nutrition to kind of keep it healthy. So now I feel that we don't do the jejunal feeding anymore because there's a time that we used to put the peg tube in and then you have another tube running through to hit the jejunum, and then but I don't even have to do that. And definitely we also realize nutrition is so important because there's several parvo study dogs where you put an NG tube in them. They get better and come out of the hospital faster. And remember, parvos are vomiting, just like pancreatitis case. They're vomiting and having horrible diarrhea, but they found that it decreases the bacterial translocation. So it makes sense. So I think that's pretty much the biggest nugget I learned in the past, like maybe 3 to 5 years that everyone's talking about feed that pancreatitis dog. What do you do? How do you go about the nutrition at home ultimately, or when you start offering food? So I'm still a huge low-fat, low-protein, and low-fiber ideally, but ultimately the fat is the main one. Remember, the proteins are also stimulations of pancreatic enzyme secretions. I think everyone just forgets about the protein. In fiber, it can delay gastric emptying, so it may prolong the duodenal stimulation. But ultimately, I'm a huge fan of the Hill's low-fat ID. I know that this is I forgot to write low-fat, because remember there's regular ID and there's low-fat. And then there's the low-fat EN now. And then I don't even think do they make Eukanuba low residue anymore? I don't think they kind of phase that out. And then the real Canine GI low-fat. And thank goodness that dogs are kind of like easier to get going on their food, but you occasionally have that little frou-frou poodle that has to have like special diet, and those are hard. So those are the home-cooked diets they might have to do to just watch the fat content and such. And just remember, if you have an animal that is on a struvite diet, the SO diets, they're super high in fat. If anything, there's a correlation I see a lot where they're coming to me for pancreatitis after being on renal struvite dissolution diet. So I'm really kind of picky of which animals I will put them on a struvite diet, because I was always taught that you should just increase water intake so the diet's not as critical. And just because you have crystals, it doesn't mean that you're going to prevent stone formation. So, but on the flip side, I have cases where I really need to dissolve that stone because they're not going to go to surgery. So, and obviously I deal with the UTI first, make sure it's not a struvite trigger by UTI. But either case, just be careful of those diets. They're super high in fat. And then again, you could do a home-cooked diet. TPN, PPN, I feel that this is definitely an option, but it takes a lot more stuff to kind of get through. So I feel like surprisingly NG2 can work great, but occasionally you can go ahead and do the TPN or PPN. The only thing is there's different types. There's lipid-based and there's non-lipid-based. And we haven't done that for a long time because we used to do it because I remember I would buy it from the nutritionist change at Ohio State, and they would ship it to us, and you have these it's like bag A, bag B, and you squeeze it, and it comes together, and then that's it's a nice little, and then you have to buy some supplementation, and you just have to infuse it. But now with the E tube for cats and the NG tube for dogs, I feel like it's less likely that we have to do it. And we do know that NG tube is technically going to be better for the gut, right, than a TPN or PPN. I like to tell owners that this may happen again. And sometimes you find out because they just get so much treats and stuff, and this is really a trigger by something that you just need to alter that. If owners are really not going to follow suit in that, I just recommend at least just choose a diet over the counter, look at the fat content, and then again, your dog is not a wolf. You don't need to buy the crazy high athletic form, and then it's like you have these poodle and a Maltese. That's just really, So I just feel that be careful of the fat content, and a lot of times it is a treat. And obviously, if you truly have hyperlipidemia, you really just need to stick with the low-fat diet. It's going to hit you again over and over again. And so try to do the less than 10% fat on dry matter basis. So remember, royal canin, low fat's the lowest one, I think. It's like 4.5%. And the low-fat ID, I want to say it's like at 8%. If you want to do home-cooked diets, those are fine. But just that's where we usually use the nutritionist at UT or wherever.
So do you usually, if you see these schnauzers that are hyperlipidemic all the time, would you just say, why don't you feed this diet?
Oh, yeah, for sure. If you have a schnauzer and you've got pancreatitis.
No, I don't mean with pancreatitis. I mean just
Yeah, forever, yeah. Even if I incidentally stumble on you because I'm pulling your blood and you're like, oh my gosh, you're so lipemic, And then there's variations. Some are crazy high triglycerides and some are just moderate. But it's like, why? You're just gambling, because they're just poster child for become diabetic and, pancreatitis, and then assuming they're not cushingoid, but I just think it's a great diet, especially if they're willing to eat it. Because think about all the gallbladder mucoceles we see. That's the other complication. So down the road, you're going to go to surgery when you're at 14, even though you've been hyperlipidemic for so long, since you were ever, little. So I'm a huge fan and trying to give them to the straight dope. And then I have this fat chart, look at your dog. This is where he is. And then, because sometimes it's it's amazing that the education of the owners, it's they just not, that they kill them with kindness with the food. And I always tell them they don't have opposable thumbs. They're not making their own sandwiches. It's whatever. They're big. It's you. You got to limit calorie intake. And I stress that they always tell me, but that's what the bag says, And I said, that's the bag that's trying to sell food, and every metabolism is different. I can't eat the same as, my daughters. Everyone's different, and then I can't stress as they get older, their metabolism slows down, and then also the richness, and we all go through that, right? All right, what you can eat in high school is not what you can eat now, and they usually go, and then you start talking about the gallbladder. And indigestion, and then there's always somebody that, I know so-and-so that had to remove, or they removed it themselves. So I think once you make that connection, you're going to, realize, you can really help them, But I did have an owner that fired me because she said that she claims that her cat was so fat and so diabetic, and she wouldn't change things, and she claims that I told her she was so fat, the owner was fat. I'm like, why would I even talk about you? I'm talking about your cat. And I think that some people have this hard time, because it's just really a sensitive topic for some. And it's one that I think that the animal really can't, they're so helpless, they're just eating because it's there. And then also it's amazing how little they know about how much their cat's eating, or dog too. Feline nutrition, high protein, low carb is often the way to go, but the reality is, especially if they're big and fat, but I feel that I don't worry about the fat content in cats, and I don't really worry about, obviously, the protein content, and it's whatever they're willing to eat. So I just kind of make sure that you kind of stay lean, but it's too hard to put them on a prescription diet. They just won't touch it. But there are some cats that really like the DM diets or the MD. And then appetite stimulant, so they're really not committed to say, all right, I'm going to put a feeding tube. Sometimes we will definitely start them on appetite stimulant pretty quickly. I'm a mirtazapine person. So I used to use cyproheptadine all the time too. Just remember the hyperexcitability that you always have to warn owners about, because always people get freaked out when they start to vocalize and run around. And if that's the case, I just shave off a little bit more, instead of a quarter tablet. And never give diazepam to cats. Remember, that's the one that they will get acute hepatic necrosis. Okay. It's very idiosyncratic. And other supplementations. So you can have B12, it's another one. And remember that you need an intrinsic factor. Okay, so remember how you get B12. When you kind of the B12 gets connected to the intrinsic factor from the pancreas, so you absorb the B12 that's natural in food and it's in the ileum, and then it goes, and the pancreas secretes the intrinsic factor. And together they meet up, and that's how you use the actual B12. And sometimes when they're really decompensating their pancreas, they can't make intrinsic factor. And then, but dogs, sometimes there's other parts that can make intrinsic factor. So I guess in humans, like they have a major issue, with that. But I know that there's other sources, but sometimes when they're so severe, I look at the B12 too. And glucocorticoids, maybe in cats, who knows? I mean, I don't use steroids in my cases. I know we've all done it when you're like, oh my God, the animal's going to die, what are you going to do? You're trying to help with the inflammation. But I don't typically use steroids in pancreatitis cases. And then vitamin K, again, they have a very low storage, so they have a low cholestasis. You're going to have to help them because they can have coagulation issues from the vitamin K issue, the blockage, because it's kind of static flow from cholestasis. And now, antioxidants, S-adenosylmethionine, milk thistle, vitamin E, selenium, these are all great antioxidants. My concern with that is that your animal's really barely eating. Am I going to cram all these things? Am I going to save your liver? Hopefully the pancreatitis settles out. All the liver enzymes goes back to normal. I never had a permanent liver failure. Now, if you have a gallbladder mucocele on top of pancreatitis, you do have underlying liver disease, and that's a different population. Or you have a cholangiohep cat. Those are ones that they probably can benefit, but I do not try to rush into that. I will say, get over this, start eating, then we can maybe start adding Dimerin, if your liver enzymes can't seem to come down, because usually there's something else going on. And heparin, do we really heparinize them? Well, we will if it's a really high coagulability risk. If I have a cushingoid dog, your platelets are 900,000. You're about to throw a clot somewhere. So that's the other thing. Like, what do they die from? I mean, in our hospital, they're going to respiratory arrest because they get to all that edema in their lungs, or they will have a stroke. They have a vascular event in their brain. They're just dead and caged. Like their caudal brainstem gets stroked out, so then they stop breathing. So, and it can happen very quickly. So I feel like if you have an animal that's very, very hypercoagulable, low molecular weight heparin is the way to go. So I'm not talking about regular heparin. So there's fractionated and unfractionated. So now heparin is, I use Lovenox. And the nice thing about that is that before you could buy the whole bottle. So it'd be like $5,000, okay? And it's like a multi-use vial, but it's hard to, get rid of that bottle. So now, like Walmart, for example, they will sell Lovenox in individual syringes, and they come in different concentrations. The same concentration, but different aliquots. Like a 0.1 ml. There's a 0.2 ml. I usually try to buy the biggest volume I can, and they're individual injections. So in humans, you're going to go ahead and inject yourself with it. So it's a spring-loaded injector. So I have the owners go pick it up, and then I bring it back, and I will put it in a sterile bottle. So we have these little like sterile vials, have a stopper in it, and I just infuse it in there, and now I have my Lovenox. And then I use an insulin syringe so that the owners can give it at home. It's just like insulin. I mean, the amount, because it's 100 unit per ml concentration of the insulin syringes. You just calculate how many units of dosing they get, and usually it's 3 times a day. And it's much reasonable. So each syringe on average like $35. It's come down in price quite a bit. So it depends. And how long do you do it for? If you're really hypercoagulable, at least a week. I wish you could go longer, but sometimes it's not as it's cost prohibitive. Depends on what the size of the animal is.
How do you decide which case to use that on? Are you using
no, I don't. I mean, I look at the platelets, if it's super high, and then you look like hypercoagulable because you're hypertensive, you have really the platelets is the big one. So I'll put them on Plavix too, of course, and maybe you're already doing PTEs. A lot of times they're coming in and their respiratory rate is really fast and it's not from pain, and you take radiographs, they look clean, so you're probably showering little clots. So those are the ones that are, and then I look at the pancreas and like, oh my gosh, it looks horrible. You're going to probably that's what's happening. If you really want to know, usually we do a D-dimer, but the downside, the D-dimer, it comes back in like 2 weeks. And so sometimes it's academic, because it's like, hey, I'm glad we did it, versus, you need to keep going, So sometimes we'll have vascular event patients that are coming in. I don't know why you're hypercoagulable, but you are. And I'll do a D-dimer like crazy high, and I'll be putting you on heparin for a while until I sort this out.
If you kind of suspect, are you going to hurt them with a little more?
No, you're not. But it's just more expense, because sometimes you start to say, all right, but no, you're not going to hurt them. Because the nice thing about low molecular weight heparin is that you're not going to be bleeding out. Because back in the days when you use heparin, you have to sit there and do it until their PT's 5 times above normal, so you're truly going to bleed, and you're trying to shoot for that. But the low molecular weight heparin, you should not be you're not going to bleed spontaneously. So it's good. So like I'll do that for like our Cushing's cases. That's adrenal tumor that I'm going to send to surgery, and I need to like kind of prepare you for this big surgical procedure because you have Cushing's. Because a lot of times,
Heat stroke.
Yeah, I guess that's a great one too. Because you guys probably see certain things. But a lot of times, just getting them stabilized, they'll be all right. But just think about all your hypercoagulable diseases. The low molecular weight heparins can be great. Prognosis is variable. Of course, it depends on what spectrum you are. And really, clinical response is the best predictor, but there are some negative prognostic indicators we'll go over. But lean animals tend to do better than obese. I suspect it's kind of like I was explaining to the owner, you're kind of fueling the fire. There's just a lot of fat that it's just digesting, and all that necrosis. You get a lot of fat necrosis. And then you can have recurrence again. And then watch for the transient diabetic. So a lot of these guys, once the pancreatitis goes away, the cat no longer needs insulin. So if I have that kind of transient one, I'll say, hey, you probably should. Well, I always send cats with glucometers home. I like that a lot because they let them do the curve and then come back in. And for some reason, they can't, at least minimally, they can collect urine. You could get Nosorb or use like fish tank pebbles just to collect some urine to look for glucose in the urine. If it's negative, you probably say, hey, you're running negative at home and you're a diabetic. You shouldn't ever be true negative for a diabetic. Usually there's still some glucose. And then it starts giving me a heads up that maybe you're starting to go low, And then a lot of them, they will develop EPI. I have a handful of them that do great, recovered like 6 months later. Diarrhea is happening, and you're trying to work that out, and the next thing you know, it's a EPI case. So I suspect it's just scarring down, and then they can't make the digestive enzymes. There's been several papers that kind of help out with like negative prognostic indicators, and that's of course shock. They're really hypertensive. They're starting to shut down their kidneys, and obviously the icteric animal is going to be a little bit tougher. I feel like cats, if it's fatty liver, it's very reversible, but I feel like a dog that's icteric, I get more nervous with their pancreatitis. And then definitely hypocalcemia, but again, usually it's because they're hypoalbuminemic, and there's definitely a negative prognostic indicator. which makes sense. If you're really bad vasculitis, you're losing albumin, and these are the ones that are effusing. And then obviously when you can't keep your sugar up, that's also a concern, or you're going septic. And then we talked about hypoproteinemia. And even if you're not, if I'm trying to be very money conscious with the owner, I will try to just do PCV total solids. You look at your total solid, but realize, it'd be nice to just do albumin. That's what you're monitoring. But the hepatic lipidosis cats, they really do need a feeding tube, because if you don't treat that, it's going to be impossible to reverse them, get them out. And of course the effusion. The bicavitary effusion are the worst, because you go into respiratory distress. And then a falling hematocrit, and then usually you're going to DIC. You're starting to bleed out everywhere. And then the melena, the gut starts to slough, and it's just pretty bad. So we did take a break, so if there's any questions, and you guys are free to go, okay? All right. Well, thank you so much for coming. I really, really appreciate it.
Thank you. Thank you.